Hello and welcome to this video on the pharmacology of diabetes. We'll be talking about some processes related to the utilization and elimination of glucose to understand why the drugs we use are effective. Along with these, there will be some snippets of side effects and other important notes. Let's go through what happens when we ingest glucose. The quick summary is that glucose gets absorbed in the bloodstream, and the increased blood glucose levels triggers the secretion of insulin to lower these levels. But there's a bit more detail that needs to be addressed in order to understand how these medications work. First, we'll talk about incretins and the regulatory enzymes. An increase of glucose concentration in the intestinal lumen stimulates the release of incretins known as GIP and GLP-1. These are released from endocrine cells located in the epithelium of intestines. So why is this important to glucose metabolism? Because they travel to the pancreas and provide a glucose-dependent effect on the secretion of insulin, which we'll focus on more later. Also, they inhibit glucagon secretion, therefore decreasing gluconeogenesis, and they delay stomach emptying. This helps to spread glucose absorption over time, limiting hyperglycemia, and may be related to weight loss. Let's talk about this glucose-dependent insulin secretion. It has been noted that more insulin is secreted when glucose is given orally versus intravenously. This finding is shown in the following graph and has been attributed to incretins. Incretins function to increase insulin production from the pancreatic beta cells in the presence of glucose. However, with low glucose levels, incretins will not produce a similar effect regardless of the amount of incretins available, because both glucose and incretins are needed for this effect to take place. Incretins are regulated by DPP-4. These are proteases that break down incretins, and they are expressed in the capillary endothelium of a few places, but in particular at the capillaries adjacent to the cells secreting GIP and GLP-1. That's all on incretins, but let's not forget that glucose also ends up filtered through the glomeruli of the kidneys. And if all goes well, all of it is reabsorbed from the sodium glucose transporters in the proximal tubules. We mentioned insulin earlier, and we're going to end this segment of glucose metabolism with a brief summary of the effects of insulin. Insulin is secreted from beta cells in the pancreas, and they function to lower blood glucose levels. And they do this in a few ways. Insulin stops gluconeogenesis, glycogenolysis, which is the breakdown of glycogen, lipolysis, proteolysis, and ketogenesis. At the same time, it increases glucose uptake by activating GLUT4 receptors on skeletal and cardiac muscle, as well as fat. It increases glycogen synthesis, protein synthesis, lipid synthesis, and the uptake of ions, especially potassium. Now that we've discussed some of the physiological processes involved in glucose metabolism, let's focus on the medications we use to take advantage of these processes when treating diabetes. We'll start this segment by continuing our discussion on insulin. Insulin is available as a subcutaneous injection and is the final medication given when all others have failed. One should be careful with insulin treatment, because inappropriate use can lead to hypoglycemia. In fact, any medication that increases insulin will likely have this adverse effect. Metformin increases insulin sensitivity, decreases hepatic gluconeogenesis, and may also reduce absorption of carbohydrates. Because of this, it is first-line treatment for type 2 diabetes and is used in the treatment of other metabolic syndromes involving insulin insensitivity, such as polycystic ovarian syndrome. It is taken orally and cleared by the kidneys. Metformin does not directly cause weight loss, but it may cause GI upset, which leads to weight loss. Nausea, diarrhea, and anorexia are common and may be intolerable in up to 20% of patients. Over time, metformin may cause decreased absorption of vitamin B12. Lactic acidosis is another adverse effect, and because metformin is cleared by the kidneys, metformin is contraindicated in renal insufficiency, with an estimated GFR of less than 30 milliliters per minute. This is because decreased clearance of metformin increases the risk of lactic acidosis. Similarly, metformin is contraindicated in patients with diabetes receiving medication for heart failure. Sulfonylureas. Sulfonylureas have three main actions. They increase insulin production from pancreatic beta cells by blocking ATP-sensitive potassium channels. The resulting depolarization causes calcium ion influx and insulin secretion. They reduce hepatic glucose production, and they increase peripheral insulin sensitivity. Sulfonylureas are given orally metabolized by the liver and excreted by both the liver and kidneys. They may cause weight gain, hyperinsulinemia, hypoglycemia, and caution should be taken care in patients with hepatic or renal insufficiency due to delayed excretion resulting in its accumulation. Moreover, you should be aware of possible hypersensitivity reactions. If metformin alone is insufficient or not tolerated, sulfonylureas may be used next in line or in combination with metformin. Diazolidine diones, also known as TZDs or glitazones, target PPAR gamma receptors. These regulate adipocyte production, secretion of fatty acids, as well as glucose metabolism. This results in increased insulin sensitivity in adipose tissue, the liver, and skeletal muscle. Overall, there is an improvement in hyperglycemia, hyperinsulinemia, hypertriacylglycerolemia, and HbA1c. TZDs are metabolized by the liver and excreted in bile. Similar to metformin, TZDs can be used in PCOS because of its ability to increase insulin sensitivity. Adverse effects to watch out for are hepatotoxicity, weight gain, fluid retention, osteopenia, increased risk of fractures, and reduced effect of oral contraceptives due to a decrease in plasma concentrations of the estrogen-containing contraceptive. Pioglitazone is currently the only available glitazone. Others have been pulled off the market due to severe adverse effects. SGLT2 inhibitors prevent the reabsorption of glucose in the kidneys via sodium glucose transport receptors. This allows for excretion of glucose through the urine. Because of this, patients may experience weight loss, polyuria, polydipsia, and are at increased risk of urinary tract infections. It is prescribed alongside diet and exercise to control blood glucose levels and can also be combined with other anti-diabetic drugs such as metformin. DPP4 inhibitors. Remember our DPP4 proteases that break down GLP-1? Well, we have DPP4 inhibitors that prevent those proteases from doing their job. This leads to an increase in incretin levels. DPP4 inhibitors are taken orally and are generally well tolerated, but keep in mind that it is associated with a slight increased risk of pancreatitis. Moreover, DPP4 inhibitors do not cause weight gain. GLP-1 agonists or incretin mimetics will be our final discussion. These drugs increase insulin secretion in a glucose-dependent fashion, inhibit glucagon secretion, therefore decreasing gluconeogenesis, and they delay stomach emptying. Delayed stomach emptying helps to spread glucose absorption over time, limiting hyperglycemia and may be related to weight loss. And weight loss is exactly one of the major advantages the GLP-1 agonist has compared to many other medications such as insulin, sulfonylureas, and TZDs. GLP-1 agonists are more effective than native GLP-1 because they are more resistant to DPP4 protease degradation. These medications are peptides and, like insulin, must be injected subcutaneously. Adverse effects of GLP-1 agonists are nausea and vomiting and an increased association with pancreatitis. We're going to conclude this video with a quick recap. Insulin is given when all else fails. It is taken subcutaneously, can cause hypoglycemia, and is associated with weight gain. Metformin, also known as glucophage, is a biguanide. It's the first line of treatment for type 2 diabetes. It decreases insulin resistance, making it an option for treating other syndromes associated with insulin resistance, such as polycystic ovarian syndrome. It's contraindicated in patients with an estimated GFR of less than 30 milliliters per minute due to increased risk of lactic acidosis. It's also contraindicated in diabetic patients with heart failure. Sulfonylureas increase pancreatic beta cell production of insulin. They can cause weight gain, hypoglycemia, and you must be wary of sulfur allergies. TZDs, or glitazones, are the only drugs other than metformin to decrease insulin resistance. This also makes them a candidate for treating syndromes such as PCOS. You must watch out for hepatotoxicity with glitazones. They are contraindicated in patients with hepatic failure because it is metabolized by the liver and excreted with bile. They are also contraindicated in patients with heart failure due to its side effect of fluid retention. TZDs are also associated with weight gain, and pioglitazone is the only TZD available so far. SGLT2 inhibitors helps to control blood glucose levels by preventing the kidneys from reabsorbing glucose. Weight loss is one of the benefits provided by SGLT2 inhibitors, but they can also precipitate hypoglycemia and are associated with an increased risk of urinary tract infections. DPP-4 inhibitors prevent native incretins from degradation. The accumulated incretins allow for increased insulin production in a glucose-dependent fashion. Therefore, DPP-4 inhibitors do not cause hypoglycemia. DPP-4 inhibitors are associated with an increased risk of pancreatitis. GLP-1 agonists are the only drugs other than insulin to be given subcutaneously. They increase insulin production without causing hypoglycemia and promote weight loss through delayed gastric emptying. Similar to DPP-4 inhibitors, GLP-1 agonists are associated with an increased risk of pancreatitis. So, that's all for this video. Thanks for watching.